Hello, everybody. Welcome to the NJAHHP Symposium on CEUs. I want to actually thank a couple of people first before we do anything. I want to thank Sharon and Carla for actually stepping up to the plate to do just about everything that had to be done. I did like maybe 1/3 of 1%. Been dealing with some health issues, and it's going to be ongoing for a long time. But that's not the point. The point is that Sharon and Carla stepped up, and they're going to do a really, really good job. So I want to thank them, and I think everybody should thank them for putting this together for us. And I hope everybody enjoys it. So whoever's I'm turning it over to, I turn it over to.
Thanks, Ed.
Thanks, Sharon.
Okay, welcome to the conference. I just wanted to say,
Push the button.
there's one.
On top.
Got it. You guys can probably all hear me without a mic. We tend to speak a little loud in our business, so I'm sure I can project. Again, welcome. We are offering 7 credits today for you, those of you that are joining us virtually. Please stay online. We will be doing attendance checks. We need to stay in compliance with IHS so that we can continue offering these conferences for you year to year. I'd like to welcome our first speaker from IHS, our East Coast, Central East Coast Governor from IHS, to give us some updates on what's going on with IHS, what we're working on, and some government affairs. So welcome, Jordan.
Thank you. I was just telling Sharon here that I always first start off by telling everybody that this isn't my day job. So anyway, my name is Jordan McMillan. I'm a volunteer, and I have the position for its Central East Coast. It's they have the territories mixed up kind of funny, but I've been in the hearing aid profession for, 17 years. So I've been licensed for 17 years. My family's been in the profession for many generations. So I actually started out in the Midwest. I lived outside St. Louis, and like I said, got licensed about 17 years ago. Started working with my father's practice, and then worked up and got into management, started to grow his practice. His practice called Belton in the Midwest. And anyway, one thing led to another. And by the way, when I was out there, I got the position for IHS governor in the Central. So I had Missouri, Illinois, Wisconsin, Minnesota, and Iowa. So I've actually been doing this about 6 or 7 years, but it's a volunteer position. Okay, so I know whenever I saw people from IHS before, I always thought that was their day job, but it's not. We're all volunteers. We do have a great staff up in outside Detroit, Michigan, Livonia. They are full-time employees. They do a fantastic job, but I'm just here representing for this new area over here. And I purchased my own business almost 1 year ago here. So I'm based out of Roanoke, Virginia. So I drove up 7 hours last night. That New Jersey Turnpike is quite dark. I felt like it's in the middle of nowhere last night. But I made it, and I just want to start off by saying that. So I have quite a large business that I have to manage. So this again is taking time out because it is that important. So I'm going to go through and explain. And after being involved with IHS for this long, I really appreciate and respect it, and even more. And so I want to first off by explaining that. There's, by the way, on the slides up here, you can note the first slide. I have my own copy here for some notes. There's a lot of information. This was put together by Alyssa Parody and Sean Drake. Alyssa Parody is the executive director. She was the government affairs and chapter leadership, chapter relations in that position with IHS, and now she's the executive director. Amazing. But there's so much that IHS does. She's put in all these slides. I'm going to do my best to just kind of get through this with you guys. It's kind of good we start a little late because usually I just take 15 minutes to go through this, so an hour has been a stretch for me. If you guys have any questions, I can try to answer them as best as I can. So feel free to raise your hand or anything if you want. But let's start out with IHS. What is IHS? So if you're not familiar, it's an international professional organization for all hearing aid dispensing professionals. We represent the profession globally, federally in the U.S., and partner with state-based associations, our chapters, to protect and advance the field. We also provide education, business resources, and much more to empower members and leaders in advance of practice. Basically, and this is probably one of the biggest takeaways here, if you guys don't already know, and actually, can I get, by show of hands, how many hearing instrument specialists are in here? Are there any that aren't? Any audiologists? Okay. So audiology, you guys have several different organizations that can represent your profession. Hearing instrument specialist, IHS is the only one. So if it weren't for IHS, we wouldn't have any kind of representation, legislatively. Alyssa actually, it worked out this way. She lives outside DC, so she actually is on Capitol Hill and she works with lobbying firms. And it's basically we're the only line of defense. So again, when I talk about advocacy and donations and becoming a member, it really does matter. And I'm sure I was thinking about it this morning. When I got into the profession, you hear all these acronyms and stuff. Like you probably start out interfacing with IHS through the distance learning course. I think most hearing specialists take that. I would say the majority. But you hear these acronyms when you hear board certifications, and we'll talk about a little bit later too. But there's a whole lot more that the organization does. Okay. Go to the next slide here. Guys, I'm not going to read everything word for word, so I'm just going to summarize for you because it's a lot of information. A lot of this information changes on a daily basis, so that's why Alyssa provides this, and I try to keep up the best I can. It's community-based. Federal and state advocacy, education, and guidance on potential changes. Okay, you can go to the next slide here. This is pretty detailed. Okay, so current state and brief. So this is kind of like where we're at right now with our profession and really just the global consciousness or the public consciousness. It was funny last night when I got in the hotel room, I turned on TV to watch the news. And there's an Eargo commercial, and there was a new one I haven't seen. It was like Eargo 6 or Max. Did you guys see that? Anybody? Anyway, it was like a 2-day sale, a Black Friday sale for that. But anyway, if you guys haven't noticed, with OTC coming on the market, it was October 17th, finally came into law. Are you guys hearing patients talk about OTC? They're bringing it up. They see the articles in the news. I had something else with AARP, there's been some articles there, so people are bringing it up. They're much more aware of it. But in general, we've been progressing towards this anyway, where many more people are aware of it. And then there's also things like Medicare, which we're going to talk about, and that's what is next. You go to the next slide. So to me, this is the past 2.5 years. This has really become kind of a hot issue. At least for hearing instrument specialists and audiologists. This has always been coming up in the past. I feel like more than 10 years ago. It always seems like every year it comes up where they want to try to add hearing aids or hearing, vision, and dental, along with Medicare, where you can bill for that. Because as we all know right now, it's excluded. But in the past couple of years, it's come closer than ever. To actually be included. And so right now where we're sitting is it actually did get passed through the House before, and this is before the last election, but you can see now the government split back again. So it is not currently, it doesn't really have much of a chance of being passed right now because of that. And you can see the last time they tried to add it into the reconciliation bill, and it lost pretty poorly there, 3-97. So if you want to go to the next slide. But just to kind of dive in a little bit more what happened, and it's still out there. It's still, you can come back up. But at first, it was only audiologists that could be added to it. And what I just did, and this is really going through a lot here, guys, is it added us to be Medicare providers and to provide hearing evaluations and dispensing services. Also, hearing aids can be defined as prosthetic devices. And then, so beneficiaries be able to access hearing aid instructions. Yeah, so basically the same. So we can open up access. If you want to go to the next slide. So let's talk about the House bill did pass. And we were able to add hearing instrument specialists to that. Now there is a Senate finance bill, which is pending, but it's very unlikely to go through. But we also got hearing aid specialists added as practitioners and suppliers. It's just the terminology they use. And so that's pretty. Any questions about Medicare? No? It's something you want to keep your eye on. So if you go to the next slide. If you guys want to, you can go to this. It's a shortened website there. So there's advocacy page there, so you want to stay informed. And if you guys are IHS members, you'll get emails and calls to action, so we can spread the word and keep things moving along. So, all right, next topic is OTC. All right, who's tired of talking about OTC? I think when I joined IHS 6 years ago, it was like really the hot topic, and it's been drug out. I'm kind of glad it's gone through now, and we're already there. So I don't think I have to talk a lot about this, what it is. You don't need a license. Anybody 18 and over can have one, and it's for people with perceived hearing loss. But there are a couple of changes that we've made. If we go to the next slide. So there was a period, I think it was 6 months, commenting period. And so they did make some changes, as you can see here. So they lowered the maximum sound output to 111 to 117 dBSPL. I think this one's really important. They revised the insertion depth limit to 10 millimeters as a maximum distance from the organic membrane, which we all know how powerful insertion gain is. And then all the hearing aids have to have user adjustable volume control. A lot of people want it reduced to ACPA only, and so it's requiring the manufacturers to have that. And then simplify phrasing throughout the device to make it easier for patients. All right, you can go to the next slide. This came up actually just around the last convention, so let's see what that's September. It was right around that time that there was a coalition. So IHS, we do work with all the other industry groups. And so there was a letter, and it was mainly had to do with, in the second paragraph, I'll just boil this down for you. The language in the law conflicted with a lot of the state laws. And so what they're doing is they're updating the FDA laws for OTC to describe the difference between over-the-counter and what we will call prescription hearing aids. So that's a really important term you're going to start using, and I think it sounds great. Now, we do not prescribe hearing aids, okay? I want to make it really clear, because that's not our scope of practice. We don't prescribe hearing aids, but we do fit and dispense prescription devices, okay? So whenever you have people come in talking about OTC, or they have questions about it, you can start differentiating between the two, saying over the counter is what it is. It's over the counter, you don't need a licensed professional, it's self-fitting. And then prescription devices, you have to go to a licensed professional. So that's what we deal with. You know, I used to call them, medical, because they were medical grade equipment. So I think that's a big takeaway there. You guys can take back to your practices right away. You can go to the next slide. So that's what I was talking about. They met, and so they sent our concerns, and they responded. And that's what the next slide is. One last thing on the next slide, one more. This is important to have, this link here, and I can make these slides available to everybody, and also there's information in the back there. But if you need to file a complaint, this is where you can send it. And I don't think we should be shy to do that. I don't think we should go out of our way. It's legit, but there's certainly going to be issues coming along, and so we need to make that available to other people and to our patients. So next slide, again, there's advocacy for that. Any questions on OTC? Yeah, you guys will heard this. Okay, next one is Fit to Serve. Does anybody here work for the VA? Sometimes, okay. Are you guys familiar with Fit to Serve, what it is? It's a bill where basically, and it says in here, there's 170 VA medical centers, but the number one health issue in the VA is hearing loss, and I heard the second one is tinnitus. So they're inundated. I think we all know that they're inundated with people who need help with veterans who have hearing loss, and because there's the backup there, and it's actually not just with hearing loss, it's many other things that you guys know about the VA. But this law was actually signed at the end of 2016, and there's also another bill signed in 2020 that allows hearing instrument specialists to work inside the VA. It's been a slog going through and working with the VA for them to accept and adopt this and integrate it into their facilities. You know, it's politics, and I can go into a lot of detail, but they had to put some hiring qualifications together, and they're not really sufficient so that everybody can work in these locations. But if you look at the bottom there, we actually finally, so we're actually seeing this come to practice, is you can see in some of these states down here, Arizona, Colorado, et cetera, where we are seeing job postings. So that's a pretty big, leap. It's end of 2022, and this began in like 2015. So you can see how long it takes for these things to go through. Next slide here. This is important so when the federal government has national qualifications for hearing instrument specialists, it's the first time they've actually recognized our profession. If you look at the second one down there, it also then kind of paves the road for us to go to a community care program. I don't know if that's what you participate in, but that's where they can go outside of the VA and use their benefits there. So that's probably the next steps there that we're looking for. All right, next slide. I'm going to skip through the next few guys, if you don't mind. It's pretty quick. Yeah. So there's advocacy. We have international standards. It's basically I think you guys are familiar with like ANSI. And then next slide, donate. Of course, we're going to ask you to donate, but the money really does go to a good cause, guys. We have a staff of about 12 people. They work full time on promoting our profession and protecting it and everything you're seeing here. Such as, if you want to move to the next slide. One more. So who here has taken the ILE? You guys don't have to take it in New Jersey? Written the ILE, the International Licensing Exam. Oh, okay. I was like, really? Believe it or not every state has adopted it. So there's like 45 states, I think, that have adopted it. But to prepare for that, if you guys have anybody in training, There's the trainer toolbox. So this is also for the trainer. There's a new trainer manual that's coming out. And it basically is just a collection of tools and everything for everybody to use and to prepare for becoming licensed. There's a new test prep. I think that's the next slide. Yep. This is actually very helpful. I've had employees take this, and so what they do is they take previously used exam questions and they put it on this online portal, and people can practice and take. It tells you your core competencies, areas that you need to work on. So you're not just going in and taking the written test blind. There's flashcards, and then there's actually now 2 practice exams, so you know right away how well you're doing. So I think it's like $89 for a month, but it's well worth it because you know the time that it takes to sign back up if you don't pass the licensing exam. Does anybody have anybody in training right now? One, yeah. So I highly recommend it. All right, next one. You guys might have heard about this. I have some information in the back on it, but there's a Attendance Care Provider certificate program. They hold it a few times a year. I've heard really good things about it. It's basically just a weekend certification program, but it just allows you to learn more about providing attendance care, and you get that certificate at the end. I want to say there's been over 100 people who come through it now. So the next one is virtual. I think that's just changed. Usually they did actually all meet up, but I think they changed it to this being a virtual, at least for this next one. So it comes up at the end of January. Next one is the convention. It's going to be in Palm Springs next year in September. It's usually in September. All right, you can move on. And so here's one thing that people are usually confused about is NBC, HIS, and IHS are not the same organization. They're actually separate. But to confuse you even more here, IHS does manage NBC and HIS now. So they've kind of like married back up, but they're still actually separate organizations. They have different boards and everything. But in the past 4 to 5 years, to become board certified, there's a lot of really neat tools that come along with getting this. And so there's a branding guide. There's that, you see that badge there in the bottom right. You can actually have a digital badge where if you put that on your email or in social media or anything, people can click on it and it takes them to ICE, which is International Certifications something. But it's a group that basically verifies your accreditation. You get a newsletter, then again, you get more tools to put that out there, because really this is the only other step for hearing instrument specialists is to become board certified. So if you go to the next slide, some people aren't sure about who qualifies. And actually, I just learned for myself, because I always knew that you had to be licensed and that you'd have to have a minimum of 2 years. I thought it was 2 years of licensure. It's not. It's 2 years of experience. So your training actually can still count too. So just keep that in mind. It has to be within the past 5 years, or and this is something you'd have to check with NBC HIS is if you have a diploma from an accredited program like this specific hearing instrument sciences program. You fill out the application. It's $225. I think is there an auction item?
Yes.
Yes. Okay, so they're going to be auctioning off a test taken here to schedule the exam. So one thing I do want to let you know is that they actually are updating this test, so I'd recommend you take it sooner than later. But along with this update, they're doing a new study guide. So that's going to be more helpful, but if I were you, if you're interested in getting your board certification, I would do this sooner than later. All right, next slide is just some quotes. Some people say, I know about it, I just know I need to get it done. It's one of those things that always kind of put off, but people are very happy once they do that. As long as you go to the next slide, you use these. There's a really nice certificate you put on the wall. You get that logo you can use digitally, like I said. So, all right, now we're going to jump back. I don't know why they're in this order, but The next slide, these are some member benefits. We'll just go through these real quick. It's 8:40, so. This is something new, and I'm embarrassed to say I don't know. I know that acronym. Is there a way that people say that, or do they say CAQH? They do? Okay, I could have sworn people, had a little name or a way to say that. Anyway, I guess hearing aid specialists can now use that ProView, and I'm not familiar with ProView, but I know this is a big deal. We were talking about it at convention, so this is something, if you can see this gal here, Samantha Sikorsky, she's really good at what she does. And so the next slide, she also helps out with compliance. So they put together this guide. I helped a little bit with this. I didn't have much to contribute. I have other people that work with me to do this kind of thing. It's its own world, billing for insurance and staying compliant. It is one of those things, it doesn't matter until it matters, so you always want to make sure you're getting ahead of the curve there, making sure you're doing things correctly in your practice and you're billing correctly, because you don't want to be, like I say, on the wrong end of that where you have somebody come audit you, and she can help with that in case you actually do get audited. So that's another member benefit. Next slide, there's a group insurance plan if you're a member. So some people didn't have access to this, especially if they're just kind of a small owner operator. So that was helpful. And then next slide. Almost done. Basically, here's all the things that IHS does for you. So again, wherever you advocate or wherever you donate money or you become a member, you're getting a lot of things with it. Free CD transcripts for you guys, or if you're applying somewhere else into another state. You actually normally have to pay for that, but it's free with membership. So that's it. Does anybody have any questions? And I went through like a ton of stuff there, just blew through it. Go ahead.
I don't know if you know this, if I the answer to this, so I know what's gonna happen, or if they have it, do you register, new client?
So the federal law says that it preempts state law, but on a practical level, and this is what other owners, we've all decided that our state still requires us to have the FDA waiver signed, and so we're still doing it. But it's a choice. It's not actually required on the federal level, but the federal government is going to come and look into patient complaints. It's the state, right? So I would rather do things according to your state. That's what I recommend. Any questions? That was the first one of the day. You need more coffee, and I know this is the most exciting stuff, but I came all this way just to let you guys know this stuff really is important, and you really should get involved. If you're not, even if you have employees, there's other associate members that you can have. It's more important than ever to stay in the loop and participate whenever these things come up. So that's it. Thank you guys.
Okay, so, is Sandra ready, or we have a few minutes?
We have a couple minutes.
Okay,
yeah.
so we have a couple minutes. One of the things I want to remind everybody is that the people sitting out in the lobby are manufacturers and exhibitors are really one of the biggest ways that we can do, they contribute to you guys getting a great education. So on these breaks, please try to visit every table, talk to them, get the knowledge that you had. And I'm going to piggyback on Jordan a little bit. IHS membership is so important. Not only does it keep you up to date, but our contributions to them allows them to work for us in government. So he's here today, and it's a good time to renew your IHS membership. So take 5, and we'll come back to Dr. Prentice talking about open enrollment in just a few minutes.
Yes.
Probably start traveling again, but I've been traveling again. Yeah, just about that. Yeah. Yeah, no problem. Yeah, it is. Yes, that's the only place you sit.
Yeah.
I mean, there's small little cities, but, yeah, I mean, the whole country has representation. I know. No county cities. You obviously.
Okay.
We stay in town on the street shopping bar area. So that's what we take for that. Yeah, yeah. So you're the bars get noisy. Yeah. Yeah. Later. Bars and yeah, right. Okay. Yeah.
Like notifications. It's end of the year. So I got it.
I don't remember. Well, that's not good. Where you headed?
Well, actually, in November, I'm gonna take my wife and son back to Vegas, and then we're gonna do, Friday, and then jump to she wants to go on a cruise up to Canada. September.
This is Paula.
Good, good.
Hey, and everyone's making a good break, but, I wanna, well, get set up. Here's my vacancy.
valuable. The idea of retirement, crossed my mind. So what you do, making that out process, I'm not. I've been really happy.
Were they in?
Might have said I could do it in an hour.
We'll find out. Look at, what do you say?
Well, she's inside of her head. What she was. Okay. Hi, so I can see you. So you're like, I see the side of your. You can't see that. Can you see this? I'm gonna bring you up. You're sideways.
Yes, I can see, yes.
Okay. I just removed you. Okay, you're good. So we'll bring it.
Okay, you can hear me, okay?
Yeah. Yeah. So
There won't be once we hang up. Yeah. So we'll bring you live in, a couple minutes, Sharon and I see
Oh, okay.
well, no, whatever.
Is it 9:00? Because what I call Google time, which is usually 10 minutes fast.
It's a.
It's weird. We'll pull you up around a little bit closer to 9. All right, thanks. Bye. Yes. Andrew, do you want more coffee?
I'm good, thank you. I had 2 cups.
Oh, wait, you know what?
No, I love it. Oh, well, you're gonna get that. It's not, nice. Once you work, well,
Hi, okay, so, we'll bring you on, I have your presentation, so I just forgot to say, so you want to change the slide to say. On the next slide, I forgot to mention that, because I have it in the system, so. Right. No, right, yep, I'm gonna have you, full screen. Your, Sandra's gonna introduce you, you're gonna be side by side, and you're gonna bring you up full screen. When you say, okay, I have a presentation, or you're at, you're gonna start. So then they can hear you, and they can't really see, you know, I can see, if you wanna like do the wand. That's okay, you can do as much as you want, but anyway, just, yeah, just like say, or, you know, so next we have this, whatever, you know. With some animation in there. Oh, okay. As a, PDF, sometimes it distorts a little bit. Yeah, I mean, let me check. You know, I haven't, oh, where this is. Particular, because this is like a process, not Zoom. So. Take away from it. Okay, okay. Yeah, no. I like it. Just saying, thought I'd throw that out there. Okay, cool, so you're good. Okay.
Are we ready to bring Sandy on?
Yeah, so what you're gonna do is I'll put her up next to you.
Okay.
And then you can see her and you can talk.
Well, I was just gonna introduce her.
Oh, yeah, nothing's cheap up in
All right, we're going to get started with our second speaker. This is Dr. Sandra Prentice. She is an associate professor at the University of Miami in the Department of Otolaryngology. Her specialty is cochlear implants. And the reason I asked Dr. Prentice to join us is because I don't know if it happens to you guys, but I know cochlear implant candidacy is constantly changing, and when asked about it in our offices, sometimes I feel quite fumbly. So we have Dr. Prentice here to actually update us on cochlear implant candidacy, referral guidelines, and other factors that affect cochlear implants. Dr. Prentice, welcome.
All right, thank you so much, and thank you for having me. I absolutely love giving this talk, but as Sharon mentioned, it is very difficult to keep up with the candidacy as it's been really evolving rapidly over the last few years. So on the next slide, what I'll show you is this is our team. So we have a very large team of a number of different specialties. So we have physicians, we have researchers, we have engineers, audiologists, psychologists, social work. So it takes a village really to run a cochlear implant program. And it takes a lot of different people since the criteria have become so much more complex. So on the next slide, I just wanted to review some of the learning objectives that we have. Hopefully by the end of this talk, you'll be able to understand our current cochlear implant candidacy. Understand that we do have a referral guideline if you're ever in doubt. It's a kind of quick and dirty just to see if somebody might qualify. And then to identify some other factors that we consider when we're looking at cochlear implants that don't necessarily include the audiogram. But I think it's really important on the next slide for us to really understand the responsibility we have to manage people with hearing loss. So right now, over 40 million Americans suffer from disabling hearing loss. And disabling hearing loss is classified as or defined as anything that's 40 dB or worse. It is now the third most prevalent chronic health condition, that's following arthritis and heart disease. And this disabling hearing loss is actually projected to reach over 711 million Americans by the year 2050. So the hearing loss continues to go up. And on the next slide, what is especially kind of complicating things is that we're living longer too, which is a great thing. But as starting about the age of 40, 50, the hearing loss starts to exponentially rise as we get older. And the impacts of hearing loss is detrimental. So as you know from talking to some of your patients, when you have hearing loss and you're unable to really communicate with others, you can experience depression, social isolation, you stop going out, overall poor quality of life, loss of autonomy. And one of the other really important things is cognition. So as we age, the risk of our hearing loss goes up, but also as you reach the age of about 60, the risk of having some sort of mild cognitive impairment also rises. So this kind of goes hand in hand, and I wanted to depict this on the next slide, that hearing loss and dementia are highly correlated. So the risk of dementia increases with the severity of hearing loss. And hearing loss is the single largest modifiable risk factor for dementia. And so it's interesting to see severe hearing loss, and I have it circled at the bottom. With severe hearing loss, you are 5 times more likely to develop dementia. So then you have a number of other quality of life issues that go with hearing loss as well. So when we think about hearing loss and what it can do, the impacts it can have on your quality of life, we have to look at the treatments too, because it's not just the hearing loss, but if the treatments are ineffective and they're still not able to function very well with the devices that they have, then these detrimental effects are still present. So in the next slide, we really have about 2 main treatment options. We have the non-invasive, which are traditional amplification, regular hearing aids. If you have single-sided deafness, there's contralateral routing of signals, the cross hearing aids. And then of course we have the invasive options, which are cochlear implants. And for single-sided deafness, it's a bone anchored hearing aids or bone anchored devices. The next slide is, okay, so now we have people that are treated. So with a hearing aid, how do we know if it's unsuccessful? How do we know when to transition from a non-invasive to invasive option? So one of the big things is, well, let's ask the patient, how are you doing with your hearing aids? But if you look on the next slide, we're seeing how are they doing with the hearing aids, but really people with hearing aids aren't utilizing them the way they're supposed to. And in fact, it shows that current estimates suggest that utilization rates are as low as 21%. And those that are buying new hearing aids there's a majority of them, those sales that are going to people who are already wearing hearing aids that are upgrading their technology. So you look at some of the reasons for low utilization, and as many of you already know, cost is a big issue. With over-the-counter hearing aids now, those things may change, but there's a stigma attached to it. Some people are in denial, and in fact, there's a study that shows it's on average a person from the minute they're diagnosed with hearing loss about 10 years before they seek any sort of treatment. So at that point, they've progressed, and now we have the risk of auditory deprivation. But some of the reasons that people are not using their hearing aids are the lack of perceived benefit. So, okay, so if you're not benefiting from a hearing aid, then you know what, maybe that's when we move towards a cochlear implant. And on the next slide, there's a number of, I'm going to have you go just one more slide forward. The benefits of cochlear implants. There's a large number of benefits with cochlear implants. In fact, it's a 2020 study of the Medicare patients. The median improvement was about 53% for speech recognition in the implanted ear over the hearing aid condition. And Medicare just recently, within the last couple of months, after about 30 years, has expanded their criteria to include people with lesser degrees of hearing loss, because of this benefit that we're seeing. So in a more recent study, over 400 cases are showing that a large majority of people are getting a benefit from a cochlear implant over a hearing aid. So we would think that, okay, well, cochlear implants there's a documented evidence for the benefit. And so really we would think that maybe that's why people aren't using hearing aids. They're moving towards a more invasive option. But if you go on the next slide, then what we see is that the utilization of cochlear implants in the US is actually quite low. So if we go back to what we were looking at, about 40 million people with hearing loss in America, and those that have about a severe or profound hearing loss is about 2 million people. And then as of 2019, there are about 118,000 that have received a CI. So that's a less than 10% penetration rate for cochlear implants. So I think largely what we can see here is that hearing treatments are grossly underutilized in general. So if we look at some of the reasons for low utilization on the next slide for cochlear implants, is that there's low referral rates. There's a lack of a clear referral pathway. So when I've talked to some of the hearing aid audiologists in the area, they don't know what to do once they do have a patient that they may suspect could benefit from a cochlear implant. There's no contact person or someone to really get them in the door. And one of the things that I've spent a lot of time researching this myself and looking at, some of the referral issues, and some of the audiologists that I've spoken with, they have a lack of familiarity with guidelines. And this is not just among clinicians, it's among consumers too. So if the general public is not aware of it, it's very possible they just don't have the impetus to know when to ask if another option other than hearing aids is appropriate for them. And then one of the clinics that I spoke with said that she doesn't make the referral. She relies on the physician to make the referral. And we know that the physician is the number one influencer on all hearing healthcare decisions. So if they're not familiar with the guidelines, or if they're not, they don't necessarily think that a cochlear implant would be beneficial, they may not refer. And so the patient will likely listen to a physician over anybody else. And another reason, on the next slide, there's some common misconceptions about cochlear implants, is that insurance does not cover the surgery, which indeed they do. Every insurance is very different. The private insurance does have different guidelines than Medicare, but those are the things that we look at on a case-by-case basis. But insurance indeed does cover the surgery. I've had some patients tell me that they think that the surgery involves this complicated brain surgery, which, I mean, it's definitely an invasive surgery, and they do make an incision and drill into your temporal bone, but it is an outpatient surgery, and people do go home that day with very little recovery time required. And the biggest one that I've heard is, cochlear implants are only for patients with profound hearing loss, which was the case several years ago. But now things have changed and things have changed rapidly. So it's hard to keep up with some of those guidelines. I've had some people say, well, age, my patients are too old for a cochlear implant, which age is no longer a factor. It used to be, again, a long time ago, but now we see that those with that are geriatric can benefit, and it's still safe for them as well. And in fact, my clinic is mostly adults and mostly geriatric. I live in South Florida, so we have quite a bit of an older population, but there's definitely, I would say the average age of my patients is about 75 to 80. So, and one of the other things that patients are afraid of is that patients will lose all of their hearing following surgery. And there is a risk that they'll lose the residual hearing on the ear of implantation, but that's not always the case anymore. In fact, we've been able to have new techniques to preserve their hearing. So if we look at this evolution and why this is so difficult to keep up with on the next slide, so cochlear implants have been around for approximately 30 years. And if you can advance to the next slide, I can show you a table of when this started back in 1985. I don't know if you can see the table. I still see that it's on common misconceptions. There we go. So this started about 30 years ago, and the criteria was that you were an adult, 18 years or older, you're post-linguistic, profound hearing loss, so no hearing whatsoever, and no ability to understand speech. So by 1990, 10 years later, they're like, okay, this is all right. Well, now we can do kids and adults. So they lowered the age to 2 years. But really from 1985 to 2014, the criteria kind of moved, but very incrementally. So by 2014 or by 2000, it was still moderate to profound sensory hearing loss in both ears. But now we can include pre and post linguistic patients. So the speech scores have also, as you can see, they went from 0% to less than 60% in the better ear in 2000. But really starting in 2014 is when we see the biggest jump and the rapid increase from 2014 till now. The criteria continue to change and change and change. So with the newer techniques that we've had surgically and the design of the electrodes that are slimmer and more flexible, they don't necessarily damage the hearing. And now we can have patients that have preserved hearing even after a cochlear implant. And, there's several studies that have shown the benefits of having both that acoustic and the electric input. And even up until 2020 is when we see that now the age has moved down to 9 months. And 2022, we have 2 companies out of the 3 now that are approved for single-sided deafness. So those with unilateral hearing loss, asymmetric hearing loss, and single-sided deafness with normal hearing on the one side are candidates now for a cochlear implant in the poorer ear. So what this allows us to do, the different kind of hearing configurations, now that we've had these different techniques and these different types of hearing, on the next slide, this expanded cochlear implant criteria shows us there's different ways that we can hear, and all 3 companies in the US are offering this. So there's acoustic and electric hearing, which is you have an acoustic signal and an electric signal in the same ear. So the idea is that we preserve the hearing in the lower frequencies, and they can use a hearing aid to help amplify that. And then in the higher frequencies where the hearing aids can't amplify as well or effectively, that's where the cochlear implant comes in. So you do this by using a hearing preservation electrode, which again are small, they're thinner and more flexible, and they're long. They're not necessarily the short electrodes anymore where this started back in 2014. They're a standard size electrode. So in the event that they do lose their hearing, even later on down the road in cases of progressive hearing loss, they can still utilize that cochlear implant as a standard cochlear implant. And for the next slide, another hearing configuration is bimodal hearing. And so this is acoustic hearing on one side and electric hearing on the other. So you have cochlear implant on one side, hearing aid on the other. All companies, again, offer some sort of option for this. Cochlear has recently partnered with Resound. So cochlear recipients can receive a Resound hearing aid at a discounted price, and that Resound hearing aid and the cochlear processors work with the same accessories, the same streaming accessories, so that they can have streaming to both ears. Advanced Bionics is a sister company now with Phonak, and they have developed a hearing aid that works with their cochlear implant. And then Medel has a number of options that they're not limited to one brand of hearing aid, but all of this offers bilateral inputs to both ears, which we know 2 ears are better than one. So on the next slide, this is why it gets confusing, right? So we have, historically, we've always relied on the audiogram to determine if the cochlear implant might be beneficial because it was really just severe. But now if we look at the criteria and we plot it on the audiogram, you can see that a cochlear implant can cover the same types of hearing loss that a hearing aid can cover. So this can cause a lot of issues when knowing when to refer, when is the best time to refer for a cochlear implant, because now we have criteria that are overlapping. And so we can't just look at pure tone thresholds anymore like we used to be able to make that referral. So on the next slide, what we know from the audiogram now is that there is no predictive value for the post-treatment benefits. So we can look at an audiogram, not just the pure tones, but also the word recognition score. So we used to be able to look at the unaided word recognition score and say, well, they have, less than 20% or less than 50%, they will likely benefit from a cochlear implant. Well, really, there's no predictive value of those unaided word scores to the post-operative aided benefit. So in fact, Dr. McCracken and his group did a study that just showed that sometimes the unaided word recognition score is better than the aided, and sometimes it's worse, but really there's no predictive value. And more importantly, as we all know, the number one complaint of people with hearing loss is the ability to understand speech and noise. So looking at an unaided word recognition score doesn't give us really any idea of how they're doing in their real life settings. And it's not common practice or routine to test speech and noise with a hearing aid. We've never really done that before. So it's hard to, make any inferences off of just looking at an unaided audiogram. So on the next slide, so what do you do? How do you know when to refer for a cochlear implant evaluation? So it is really difficult. And just looking at an audiogram, as we mentioned, it's very difficult to just make any sort of assumption that they will or will not benefit from a cochlear implant. So Dr. Zwollen and her group on the next slide came up with a 60-60 referral criteria. So what they did is they looked back at, it was a retrospective chart review, and they reviewed hundreds and hundreds of charts of patients who that were able to get a cochlear implant, and they looked at the unaided audiogram. And what they found is that those that were presenting with a pure tone average of worse than 60 dB at, the 5, 1, and 2, and they had an unaided monosyllabic word score of less than 60% in the better ear, that they would likely meet cochlear implant criteria. In the traditional sense, obviously not the SSD or the asymmetric, but in the traditional sense, if they meet these two guidelines, then when that's used, they had a 96% detection rate and 34% false positive rate. So, and granted, you can't just look at the audiogram, you also have to ask the patient, are you doing okay with your hearing aids? And if they are, obviously a referral is not appropriate. But if they're saying that, I'm not really doing that well, I don't feel like it's benefiting me much, their quality of life is declining, then a referral would be a good idea. So this is something that you can use in your clinic if you're having a difficult time with a patient, not knowing when to refer. Just kind of look at that, and you can always make the referral. It doesn't necessarily mean that they are signed up for surgery. It doesn't mean that they will qualify, and it doesn't mean that they will, even if they do qualify, that they will go forward with it. So that's just kind of a way to screen your patient to see if they might fit cochlear implant criteria. But with cochlear implants expanding and the criteria expanding, and it's requiring a lot more than just the audiogram. So on the next slide, you can see that when we determine candidacy, it is far more than just speech recognition in the audiogram. So we need to understand their medical history, their hearing history, their goals, their lifestyle, their demographics. You know, do they have the family support? Do they have are they able to get to the clinic for follow-up and things like that? So on the next slide, you know, it really just required an audiologist and maybe a surgeon, because all it took was a medical examination, imaging, and maybe just to make sure they have an ear, and an audiology exam. But now there's so much more that's involved in cochlear implant candidacy criteria. So it's not just the medical exam, but of course there's still imaging is very important. The audiological exam, which isn't just the pure tones anymore, it's a lot of testing with their hearing aids. There is genetic testing now, especially with the kiddos that are coming through with hearing loss. We'll do genetic testing. There's a speech to language evaluation that's necessary. As we mentioned before, you know, with the increase in age of risk of hearing loss, there's also risk of cognitive impairment. So we do have cognitive screeners now that we conduct, and all of this is just to help us more with counseling. With cognitive testing, you know, one of the signs of cognitive decline, even if you don't have hearing loss, is your inability to focus and understand speech and noise. So, so we use that very diligently when we're counseling on realistic expectations. We do have psychological exams if somebody is expressing any sort of stress or anxiety, depression, that's maybe beyond that of the hearing loss. Then we do have a psychologist on our team. We do quality of life questionnaires, making sure that we can get an idea of how they're functioning, how they feel like they're functioning in their present situation. And we do counsel a lot on realistic expectations. So before, you know, when it was just profound, we would counsel and just say, hey, you know, if you get sound awareness, that's great. Now it's, will you understand speech? How much speech will you understand? What's the sound quality going to be like? So we do spend a lot of time on that. So on the next slide, with all of those kind of things that we take into consideration, the cochlear implant team needs to be large and obviously multidisciplinary. So these are all of the team members involved, and it's not just professionals. So we do have some advocates that, you know, previously implanted peers. So those who are thinking about it, we can put them in touch with somebody who has been implanted just to talk about their experience. Family members and caregivers are an integral part of the cochlear implant team. Make sure they have the support. And again, you know, can they get to their appointments effectively? Because it's become so difficult, and there's you know, so many different ways you can evaluate. The next slide, the American Cochlear Implant Alliance has pulled together a few of us to really go through some guidelines of what should be involved in a cochlear implant evaluation. So myself and some of our other colleagues are coming up with some of the guidelines and testing that should be done once they're referred, just so that we can make sure we're looking at the whole patient and not just their audiometric profile. So what happens in a cochlear implant evaluation on the next slide is it's a extensive case history and needs assessment. So, you know, what are their goals? What do they want? What is their need for this. We do a hearing aid verification. So when they come in for testing, we'll do some real ear measurements just to make sure their hearing aids are fit. And if they don't have hearing aids, or if their hearing aids are very old, we do have stock clinic hearing aids that we can put on their ears for the purposes of testing. The aided testing is extensive. We do a lot of testing with words and sentences, which I'll show you an example of in just a minute. But the most time consuming is the counseling for the patient, counseling for the family members on realistic expectations, that, this is, although cochlear implants do show a lot of benefit, they're not perfect. They're not restoring hearing back to normal. They're still, hearing and background noise is still going to be an issue. While improved, they'll still have some time. So there's got to be that expectation that if you go into a crowded restaurant and you're sitting at a table of 10 and there's music playing, that you're not going to be able to follow every single conversation that's going on. So on the next slide, this is after we verified the hearing aids, this is kind of the setup that we have. So we have a speaker. I'm not sure why she's making a thumbs down, but maybe because a lot of people get frustrated during this kind of testing, but they're seated at 0 degrees azimuth, about 1 meter from the speaker. They have hearing aids in. If it's single-sided deafness, we do spatially separated, where it's at 90 and 270 versus 0 and 180. And we do have the ear plugged or muffed on the other side if needed. And so what's involved with the speech testing, so we have on the next slide, the minimum speech test battery. There's the AZ Bio sentences in quiet. It's 4 voices, 2 male and 2 female. And the way we score it is, so they'll read, I could hear another conversation through the cordless phone. If they miss 2 of those words, then we mark those incorrect, and how many words they got correct out of the total. And then we after they finish all 20 sentences, then we score up a % correct. We also do this same test in noise. So the noise is a multi-talker babble. It's like a cocktail party. We put that either 10 dB or 5 dB below the target, and to determine how do they understand speech and noise, and we calculate it the same way. So the next part of it on the next slide, this is the CNC word test. So we do this with hearing aids, and we just mark how many words they get correct. So for instance, on the first one, if the word is goose and they said moose, we give them credit for 2 of those phonemes. And then we calculate how many words they got correct and how many phonemes they got correct. And if you look closely at that other table, so the candidacy criteria has kind of started moving towards this score over the sentence scores. The sentence scores are still very important for us to use as realistic expectations, but the word scores are isolating more of that auditory capabilities, versus the sentences, especially in noise, require a lot more higher executive function and processing. So if there is any cognitive impairment, we want to make sure that we're treating the hearing loss and not trying to treat something that is non-auditory in nature. So on the next part, so we have averages of how these patients will perform. This is a paper that was done by Dorman and Gifford. And what we see is that in as average cochlear implant user, so this is, another retrospective chart review of several hundred cochlear implant users. And if you look at the quiet score, they're near normal. Their ability to understand speech in quiet is near normal at +10, while somebody with normal hearing will get about 100%. Those with a cochlear implant average around 50 to 60%. So, and then obviously when the noise becomes louder, that score will go down. So these are kind of the averages over time. So this is what we like to show them ahead of time, that, even with a cochlear implant and surgery, it does not mean that you're going to have 100% word understanding, especially in noise. So we do counsel very conservatively, and a study by Dr. McCracken had shown that those that were set up with lower expectations at the preoperative evaluation demonstrated a higher postoperative quality of life. So we want to keep those expectations in check, because if we set them up for really high expectations, and even though they're noticing improvement and we can document an improvement, if it doesn't meet their expectation, they may not feel that their quality of life has improved. And so we can capture some of that on the next slide with some of the subjective questionnaires that we do. We do the SSQ, we do a cochlear implant quality of life profile, just to really gauge how they're doing. So we do that preoperatively, and then at 6 months and 12 months postoperatively, and then once a year after that. Another one that we do is a mental health screener to kind of gauge how their mental anxiety and depression. So if it's a certain, it's just a screener. So if they score a certain number, if it's scoring high, then we will refer them to outside resources for some management of that. And then, of course, as we mentioned before, there are cognitive screeners that we do just to see where their cognitive function is. It gets a little hairy. We're not, obviously as audiologists, we don't have the scope of practice to diagnose anybody with anxiety, depression, or cognitive decline, but we can use these screeners and say, I can tell you that the score is just a screener. It's above norm. It's above what we would expect. So we just would refer outside for that diagnosis and a more thorough evaluation. So I wanted to go over some cases of patients that we've seen in our clinic. So on the next slide, this is our first case. It's a EAS case, meaning that it's an electric and acoustic stimulation. The patient was 58 years old. He had a long-term sensory neural hearing loss. He had been wearing hearing aids for about 17 years, 20 years at the time. Very active. He owns his own company. His hearing aid audiologist had told him that his hearing is too good for a cochlear implant. And he kept coming in for testing, or he went somewhere for testing and saying that he was scoring too well for a cochlear implant evaluation, but yet he is still complaining that he can't function very well at work. He can't hear on the phone or in meetings, and it's really impacting his quality of life. So what we discovered when we talked to him is that when he underwent a cochlear implant evaluation, they did some testing with aids, but they did the older testing, the hearing and noise test, which is no longer used because of the ceiling effect, that too many people were scoring way too high and we couldn't measure improvement anymore. So that's when we moved to AZ Bio. So when he came in, on the next slide, you'll see that this is his audiogram. So he has pretty good low frequency hearing and profound high frequency hearing. So even with the best fit hearing aids, we know that they're not going to be able to touch those high frequencies to bring him into a good audible range. And so when we tested him, we tested his monosyllabic word scores. So again, we score both on words and phonemes, and he scored really quite poorly, only understanding 38% on the left side, and on the right side, he was understanding 44%. When we looked at his sentences in quiet, it was 68% and 81%. And, 81% is pretty good, but if you look at his case history, he's not in quiet. He owns his own company. He's very active, and he's around noise. So that's not really a good gauge of how he's performing in his real life. So if we put him in the most complex noise condition, which is likely what he's experiencing on an everyday basis, his scores go all the way down at the very bottom line there to 31% and 45%. So it was definitely, at this point, we decided that, if he's motivated and he's ready and he wants to give it a shot, then he definitely meets candidacy criteria. So on the next slide, we'll look at his pre-op. There's his audiogram on the left side, and then his post-op. So he was implanted on the left ear. He did lose some hearing, but it is still functional for that electric acoustic stimulation. So he was able to wear that hearing aid, and it's like a hybrid device. It has a hearing aid and a cochlear implant on the left side. And on the next slide, we'll show you a little about how he's hearing now. You can see that the left side, the hearing came up just a little bit, but when we test him at initial activation, oftentimes they still have some blood behind the ear. So he's still, he's recovered a little bit, but still not to where he was preoperatively. But you can see his improvement. So his pre-op is depicted in green. His word scores, his sentences in quiet, his sentences in noise. The biggest improvement, as you can see, and this is at 3 months, he was at about 35% and the left ear, and 3 months later at +5, he's at over 60%. So definitely benefiting from that. And for our next case study, so, you know, this is the newest criteria. So the cochlear implant for single-sided deafness. This has been recently approved. It does help with localization. It's not something that they can localize as well as somebody with normal hearing, but they do definitely get a little bit more direction. It has been shown to help with some tinnitus perception. It doesn't cure it. And if somebody comes in and says that they want a cochlear implant for the sole purposes of improving their tinnitus versus improving their hearing, it's a different conversation. But with a cochlear implant for an SSD, that we do continue to see these same benefits that we do for bilateral hearing loss, and that's improved quality of life and a subjective benefit. So just as a review on the next slide, MED-EL, their indications are they have to be 5 years and older. They have to have less than 5% on the CNC word test, obviously in the ear to be implanted. They do need to have some sort of amplification trial, which is usually with a cross device. And cochlear, they were just approved for pretty much the same indications, but just this year. So this is kind of what the hearing loss would look like. They have completely normal hearing or near normal hearing on the one side, and then profound hearing loss on the other. So when we look at a case, so for case number 2 on the next slide, we have a 52-year-old male. He had a history of head trouble from a motor vehicle accident. So he's had 40 years of duration of deafness on that right side. So it's one of those things where we're going to counsel him very differently than we do somebody who has a progressive hearing loss. He's been deaf on that side for 40 years. There's auditory deprivation has set in. So our counseling at this point may be, you might get some sound awareness on that side and a little bit of direction, but understanding speech on that side will probably continue to be very challenging for you. So his preoperative, you can see in the green box in his right ear, he didn't have a response to word recognition scores, and that's unaided pre-op score. On the next slide, we'll see his preoperative. They did put a hearing aid on that side just to see if there's anything that could be improved. There was 0% understanding with the left ear masked. We did do a promontory stimulation just because when we do aided testing, even though we verify it, sometimes we'll do a functional gain, and he didn't even show any responses to the hearing aid. So we want to make sure that the nerve is still active or viable for a cochlear implant. So despite his history, he decided that he wanted to go ahead and go through with the cochlear implant. And in the box below, you can see his scores. So he went from 0% to 26% in quiet. His CNC words on a list of 25. We typically do 50, which is all the way to the right. He improved from 0% to 24%. So this is a very different, but still the expectations were that he might get sound awareness. So the fact that he has some word understanding is really impressive. So that I just wanted to show you a case of single-sided deafness. And then of course I have just one more case. This was one of my patients that I saw recently. He was 81 years old. His etiology, he believes that he was born with some hearing loss, and then over time it's progressed due to noise exposure. He was in the Navy. His main complaints are his difficulty with television, telephone, and in small groups. And this was referred to me from someone who had used the 60/60. So as you can see from 5, 1, and 2, the pure tone average is 60 dB or worse. And the word recognition score in the better ear is 60% or worse, and in the poorer ear it's 48%. So they referred him for a cochlear implant evaluation. So I performed this on the next slide, and here are his scores. He did qualify for cochlear implantation on both sides, but what ultimately, so in quiet, he's scoring right around 60%, and in noise, what's interesting here is in noise, if you look at his +10 score and his quiet score, they're really about the same. So when I see something like that, it tells me that maybe the testing is more testing his memory and cognition versus his auditory abilities. So when I was testing them, if you listen to the AZ bios, they're very quick. And so he said that a lot of times he would hear the sentence, but he couldn't remember what they said. So that's why his scores look really the same. But so we counseled, and I was really trying to get an idea of what does he want the cochlear implant for. He ultimately chose not to proceed because really, when we tell them that you do have to do some listening exercises, it's not something where you just put, once you get activated, you hear and that's it. It's, it takes time for your brain to adjust to that new sound. And he admittedly said he would not do listening exercises. And after talking with him more, he's like, really, I just want to hear the television better. I don't interact with people. And I asked him, do you not interact because you can't hear? Do you not interact because you just don't want to? And he basically said that he doesn't like people and he doesn't want to interact with them. So we decided that maybe a cochlear implant isn't the best for him. Just looking at his lifestyle, I don't think he would have really gotten a lot of benefit from it. So I referred him back to his managing audiologist, his hearing aid audiologist, and they had fit him with a new set of hearing aids, a little bit stronger hearing aids, and some streaming accessories for the television. And just recently we found out he's doing actually quite well with that configuration. So the cochlear implant isn't for everybody. So what I'd like you to take away from this is that no referral is a bad referral. So if you see a patient that, think about your patient and they are constantly upset with their hearing aids or anything like that, you can refer them and they can at least learn about the devices and see if they even meet the qualifications. And just by referring, it doesn't mean that we know they're going to meet candidacy, and if they don't, it's okay. At least we have the information now, and at least they know that they're with the best that they work with, and that's their hearing aid. And having them undergo all of this testing and all of the subjective questionnaires, all of that doesn't commit a patient to surgery. So a lot of, just as I showed you in that last case, we went through all this testing, we went through extensive amounts of counseling, and he decided not to pursue surgery after all. And it's and that's perfect for the patient. Every patient is different, and we look at them all differently and individualize their plan. So on the next slide, what if your patient's not a candidate? Most patients find a CI evaluation very helpful, regardless if they meet candidacy. So they just learn a little bit more. Again, like I mentioned earlier, there's a lot of places that aided testing is not part of the routine. And when you're in a busy clinic, you can't just be testing everybody all the time and doing this extensive testing on them. We've got busy clinics, we have a lot of patients to see. So it isn't a part of that, but this at least gives them, when they're referred, they get some insight to how they're performing and what we consider a good candidate and what we consider, they might benefit or not benefit. And if they're not a candidate, we refer them back and we give them back to their managing audiologist and say, you can work with them about hearing aids or assistive devices. But what we don't want you to do is if you see a patient that has, something like severe to profound hearing loss and really just looking at the audiogram, we know that the cochlear implant or the hearing aid may not provide benefit. You don't want to say, well, let's just see if they work first, and then we'll refer you. If they've been trying hearing aids for a while, and you've tried several different sets of them, several different configurations, several different levels of technology, probably it's if it's not working, it's not working, and it's maybe time to refer. A cochlear implant is no longer a last resort for treatment. So it used to be where you just had nothing left, but now it is a great effective treatment to mitigate some of those, especially precipitously sloping hearing losses. So it's not necessarily something that's meant to, there's nothing else for us to do for you. We can intervene a little bit quicker now. And if you're not sure if a patient is clear cut, then just ask a CI team, or ask somebody who's working with them. And maybe, I've had several people send me pictures of audiograms, and I've had discussions with them, and we'll just talk about it and see if it's an appropriate referral. And again, it's not just based on the audiogram, like, your patients too, if they're willing to do the work to make sure a cochlear implant will be successful for them. What you don't want to do is assume the patient is too medically involved for a CI. I don't see a lot of the kids, but we have multiply handicapped children that are successful with hearing aids, with cochlear implants, and that's not for me to decide. That's for the surgeon to decide if they can sustain the surgery and make the most of it. And then lastly, you don't want to assume that a patient is too old for a CI. So with the criteria, the expanded criteria, just to kind of sum things up here, the CI criteria has expanded to, on the next slide, for those with more residual hearing, shorter durations of deafness. We can implant all the way down to 9 months of age now. We do testing in noise for candidacy versus just looking at the unaided word recognition score. Single-sided deafness, asymmetrical sensory neural hearing loss. So even if they have a mild hearing loss on one side, but maybe a moderate to severe hearing loss on the other, we do test the ears individually to look at the benefit with the hearing aids. So, and fluctuating hearing loss, this one's a little bit more tricky, but with the cases in Meniere's, if we see one ear is, completely gone from Meniere's and the other one is fluctuating, we may consider implanting, obviously, the ear that's bottomed out. So if the other one is fluctuating and then eventually bottoms out, then they're not completely deaf. So a lot of the criteria has really expanded to almost anybody who is reporting to you that they're just not doing well with their hearing aids anymore. And as I mentioned earlier, it's not for everybody, and we can certainly look at the whole patient. We're not just going to judge them based off of, even if they meet candidacy, are they willing to put in the work? Are they, do they have realistic expectations? Do they have the support to do this? So in conclusion, on the next slide, the CI evaluations are very complex, not what they used to be. It's more than just the audiogram, it's the entire patient we have to look at. A skilled team is really necessary to manage the whole patient. So even if we can improve some of the hearing, if there's, we need to make sure that, for some of our patients that are having a hard time at home or whatever, we have a social worker to help mitigate some of that. So we want to set them up for success. So it is an excellent treatment option for those that are really continuing to have issues with their hearing abilities. And it is something that we can continue to work towards to improve their quality of life, which is really the goal of what we're all doing here. So my references are on the next slide, and I do want to thank you for listening. I have my emails listed on the next slide if you have any questions, or if you want to contact me for anything, I'm more than happy to correspond with you. So I'm not sure. I can't hear anything. There we go.
I was asking about bimodal patients and referral where we would get our patient back for the bimodal fitting. And how do we communicate that with our referral?
Yeah, so if somebody comes in and they are a bimodal hearing aid fit, if you work, so for instance, if we use Cochlear, for example, we'll do the cochlear implant, and then if you work with Resound, we would give you the order form so that they can order it and they get the discount through Resound because they have a cochlear device. And then what we do is once we do have to link them up in the cochlear implant software. So we just have to tie the hearing aid and the cochlear implant together. But then once that's done, they can go back we would refer them back to their managing hearing aid audiologist, and they can have the hearing aids program there.
So you actively would refer back to the referral source that sent them to you to begin with?
We often will. Now it is some of the patients don't necessarily want to go to two different places, but we do encourage them, if they're having a hearing aid issue, then we do encourage them to go back to their managing audiologist for the hearing aid part of it. But if they're in the clinic and I have to balance the two, I do manipulate the hearing aid from time to time just to, if they're there and if the hearing aid is now too soft because of the mapping changes I made. So we try to refer them back all the time, but if sometimes it's easier for them to just be getting services at one spot.
Yeah, I certainly understand that.
Yeah.
I wonder what you think of the choices that the patient has for bimodal options, as far as one company seems to have a lot more options, one or two, than one of them does. Do you prefer one over another because of bimodal? Or when a patient would probably be bimodal?
And I think to make sure I understood your question. So you're asking if, based on the implant company, do they have more options with one implant company versus a different one for bimodal?
Mm-hmm. Yeah.
Yeah. So really, with Cochlear, they just have Resound. With Advanced Bionics, they only have Phonak, and it's just one hearing aid that works. And then for Medel, they have a number of different options because Medel isn't tied to one company, but the hearing aid has to be specific in that it has to have the capability to connect to an Android phone, and it has to have some Bluetooth. So it's limited. So when somebody is choosing a cochlear implant device, we do leave that mostly up to the patient with guidance. So we will ask them about their lifestyle. So for instance, a lot of my patients who are older, they can't really, some of them don't even have cell phones. So having all these other accessories for a cochlear implant is something they're not going to use. And so in that case, if, an Advanced Bionics and they choose the Phonak hearing aid as an accessory, so they're not even, it doesn't even, there's no out-of-pocket cost for the hearing aid other than a fitting fee, but it comes as an accessory. So those are the kind of patients that I would say, all right, well, you don't need all these other accessories. So, but there are more options for Medel to have different types of hearing aids to work with bimodal with different manufacturers. It is a little bit tricky to find the right one and to make sure that it works with to make sure it's compatible with their streaming devices.
Yeah, have you had any experience with patients who have mixed hearing losses where the bone conduction has started to deteriorate, such as atherosclerosis, or patients who have had a history of middle ear fusion, but now the hearing has gotten worse for air conduction as well as bone conduction?
Absolutely. So we have quite a few that most of the time it is from otosclerosis that they have these severe mixed hearing losses. We do take a very close look at their bone scores. If their bone scores are still kind of following that of a, you know, moderate to severe hearing loss and their air scores are you know, severe to profound or something like that, we definitely do have quite a bit of experience with cochlear implants in that case. If the bone scores are still well within, you know, something that maybe a BAHA can manage, then we do talk to them about their different options. Otosclerosis, as you know, is very tricky when it gets to an advanced stage, and it's, you know, oftentimes they'll have 2 failed stapedectomies at that point. That there's some ossification there, so it can get pretty tricky with a cochlear implant. We do counsel them a little bit differently.
All right, well, thank you very much for joining us today, Dr. Francis, and we will have all of your information available, so anybody can contact you whenever necessary.
Sure. Thank you so much for having me.
We'll talk soon.
All right. Bye-bye.
Okay, we are going to take about a 5-minute break again. Please visit the exhibitors, take some time to use the restroom. And also I wanted to mention 2 things. For our virtual attendees, you are welcome to ask questions as well. Please send them to our website or our email address, which is njahhp@gmail.com. Should be on all of your invitations. Also, our association has a silent auction in play. So there's information for that on the back table, I believe, or let them know. And it's going to be going for a couple more weeks, so definitely take a look at that. And we'll be back in about 5 minutes.
Well, I want you, let's.
It would ring on my wrist. Is one of these mine?
Yeah.
Awesome.
No, it'll ring on my wrist. I see it. It's down there. Yeah, my phone's on silent.
Okay.
Great. Welcome back from break, everybody. Our third speaker for the morning is Sherry Eberts. She is a hearing healthcare advocate. She is an author. She will be having a book signing outside of here when she's finished her talk. Her book is called Hearing and Beyond, Live Skillfully with Hearing Loss. Sherry's going to help us have a better understanding of living with hearing loss, so we have a better understanding of how to help our patients, give them better care, and understand their path a lot better. She also has a blog in a community, living with hearing loss. And she is a producer or an executive producer, right? We Hear You, which is an award-winning documentary about living with hearing loss. So on to Sherry. I hope I didn't butcher your credentials too much.
Well, thank you so much. It's great to be here with all of you this morning. Thank you for that warm welcome. So like Sharon said, I'm Sherry Eberts, and I'm a hearing health advocate and also a hearing aid wearer. So definitely here today to discuss that perspective, which I think is one that is often missing at conferences. So very excited that it's being included in this one, so thank you for that. So I'm excited to talk to you today about patient-centered care from the person's perspective with hearing loss. And I plan to tell you a little bit about my hearing loss journey, try to explain as best I can the experience of what it's like to have hearing loss, share some of my experiences with hearing care professionals over the years, and then lay out my formula for person-centered care from the patient's perspective. And throughout all of this, well, are we gonna put the slides in? The worst part of any presentation is like the technical slides and the videos, so thank you for bearing with us on that. And then throughout the presentation, I'm going to share some case study examples to highlight some of the common pitfalls that people fall into. And then of course, some questions. And then there'll be a second presentation that will be more from the patient, a different point of view from the patient, but sort of the skills that the patient needs to use in order to live well. So the first part is sort of the skills the practitioner needs to do to help the patient, and the second is sort of how we help ourselves. All right, so let's get started. And I'm gonna go to the next slide. And I thought I would start off and just tell you a little bit about my hearing loss story, because I think that every story is powerful, and it's just so important just to give you a little bit of my perspective. So my hearing loss began, I noticed it when I was in my mid-20s, when I was in graduate school. And pretty quickly into the first semester, I started missing things in class, right? Maybe somebody made a joke, maybe there was a comment that was made as an aside, and I would be left looking around the room, trying to figure out what was so funny. And I knew what was happening. I knew that I was developing hearing loss. My father had developed hearing loss as a young adult, and his mother had as well. And I had been hoping that it would skip my generation, but obviously no such luck. And I felt like I was entering a path that really had no escape, and one that had really destroyed a lot of my father's life. So I was terrified. I went to get my hearing tested, and I don't remember much about that first appointment other than the diagnosis, which was mild hearing loss. It's too slight to do anything about. Monitor it and come back later. And so this gave me the perfect excuse to just ignore and deny and pretend that I didn't have an issue, even though I did. But as the years passed, I noticed that I was having trouble hearing at work, and certain clients were giving me lots of trouble. And as I suspected, I needed to go back to a hearing care professional. So I did, and this time it was recommended that I get hearing aids. And I was really devastated. The stigma surrounding hearing aids was very, very strong in my home growing up. My father did anything that he could to hide his hearing loss. It was an unmentionable topic. And eventually he became very isolated and withdrawn from everyone in his life and in the family. I remember family events where he'd be sort of off sitting at a table by himself with his back to the festivities. And I remember as a child, I went up to him and I said, "Why are you sitting here by yourself at the party?" And he said, "When people want to talk to me, they know where to find me." And as a child, I thought, well, maybe he's just shy, I don't know. But as I developed my own hearing loss, I understood the truth, that he was probably having trouble hearing in that space with all the background noise. And he was just exhausted and really just couldn't put in the effort anymore to participate. So my experiences with my father were definitely impacting how I felt about getting hearing aids. And I knew that I needed them, but obviously I wanted them to be as small as possible, right? So nobody would see it, because he taught me that. I remember getting the hearing aid molds taken. My audiologist was very, very gentle and kind, but I had never put anything into my ears like that before. And I remember the gel hardening, into the mold, and it was painful, and all sound receded. And I just sat there thinking, is this what it feels like to wear hearing aids? And I just went home and cried because it just was such a foreign experience. So I hated my hearing aids, obviously, when I got them, because my father taught me that as well, unfortunately. But I did have to wear them. At work, I would sneak them in, to meetings before important meetings, and I would rip them out as quickly as I could afterwards. And I needed to wear them more and more as my hearing loss got worse, but sometimes I did, sometimes I didn't. And I was really just following in my father's footsteps of shame and isolation. But then I had children of my own, and everything really changed for me because my hearing loss is genetic. I worried that maybe I would pass it on to them. They still don't know yet, they're in their teens. But I saw them watching me do the same things that I had watched my father do. And I knew I was passing on to this next generation the stigma and the discomfort with hearing loss, and I needed to break that cycle. So I did. I started wearing my hearing aids all the time and working to educate my family and my friends about how they could help me hear better. I remember one Thanksgiving, probably a lot of years ago at this point, where I rearranged the whole seating arrangement so that I could have a better seat. It was sort of the first time that I had really taken that action. And my family was very supportive about it, and it encouraged me to continue to advocate for myself. And now I do advocacy more broadly, obviously coming and speaking. I have a blog that Sharon mentioned, livingwithhearingloss.com, where I'm trying to share my experiences with hearing loss. And also sit on the board of Hearing Loss Association of America. And today I see my children are still watching me, but now they're learning a better attitude and they're learning the skills that they might need if they should develop hearing loss themselves. Okay, so the next slide, the pandemic really highlighted the difficulties that people had with hearing loss and with communication. And Carla, are we gonna do the next? Thank you. But there's not really a lot of awareness about hearing loss. And so what we tried to do is create a documentary called We Hear You that Sharon was mentioning. And unfortunately, we don't have the sound, but this is the trailer for it. So you'll see the captioning. effective it is to watch a trailer with no sound. But maybe it is sort of an interesting experience, right? Because it's a little bit of how people with hearing loss are watching things, and that's why the captioning is so important in terms of media and all that. So I hope that gives you a little bit of a sense of the documentary. We put it together for a couple of purposes. First, to bring the hearing loss community together. We felt like in major media, often the deaf experience is shown rather than the hearing loss experience, and so wanted to also raise awareness about that. But what is it like to have hearing loss? So I hope you can tell a little bit from my story, as well as from the trailer, that when you have hearing loss, it impacts every aspect of your life. And it changes the way that you see yourself, especially if it's something that you developed later in life. You may feel less worthy of love. You may feel less competent. You may feel stupid when you don't hear things properly and you answer questions wrong. So the stigma that we feel and we put on ourselves sometimes makes it harder to ask for the help that we need in order to communicate, and that just compounds the problem, right? It also creates communication barriers that make it more difficult to create and sustain relationships. And so we might avoid friends that are more difficult to hear. I know that there are friends of mine that I sometimes still to this day avoid, even though they're very kind and they do their best, but they're tiring for me because I can't hear them as well. It's also tough in romantic relationships. Frustration can be a factor if communication is not flowing so easily. You lose some of that feeling, some of that closeness. And hearing loss is also exhausting, and you all know this, that it takes a lot of processing power, right? I describe it as sort of a game of Wheel of Fortune, right? Where you're trying to sort of take the sounds that you have and then use your ID, what you know about the context of the situation and speech reading cues and other things to put it all together. And then of course you're not done because you need to reply, right? You need to continue the conversation. So it takes a lot of mental energy to communicate. And the world's also not set up for people with hearing loss necessarily. Everywhere we go, there are ramps and other things which help wheelchair users. And this is terrific, and this is how it should be. But we wish that we had access to those types of things for people with hearing loss just as easily. Okay, so the next slide, I want to talk a little bit about my experiences with hearing care professionals over the years. And, I think the influence that a hearing care professional has is really paramount. So you need to understand how important you all are in terms of setting us on the correct journey and the correct path. And as I told you, I arrived at my first appointment with an audiologist when I was in graduate school, and they just sort of sent me home, right? They said, well, there's nothing we can really do for you. Go back to class. Despite the fact that I was having trouble hearing in class. I was there for a reason. I needed help. So I think thinking back on that standard of care is definitely disappointing. And I have seen definitely a number of hearing care professionals in my life since that time, obviously. Only one of them has asked me, what are the most important situations for me in terms of hearing? And only one, which is a different one actually, ever tested how well I was hearing when I was wearing my hearing aids. And so I tell you this because, not that I want to complain, right? Because obviously I'm doing very well with my hearing aids, and I have my hearing care professionals to thank for a lot of that. But I think it's also just to explain the patient experience and sort of some of the things that we walk in and we walk out with. Okay, so moving on, let's talk about person-centered care and a little bit about what it means to you. And I am going to go through my definition, like I said, but I thought before we did, I would take just a little poll to see where you guys are on this. What you think of person-centered care. So is it a critical part of every interaction you have with a patient? Maybe something that's useful for first-time patients only, or a nice to have. Okay. But there's not a lot of time. We'll talk about some of the barriers later. And an afterthought, my job is really to fit hearing aids. So it seems like this is a very person-centered, focused crew here, so that's excellent. Okay, so let's go on to my definition, the next slide. And in my definition, there are 5 main parts. And the first is to partner with your patient. And this means taking the time to understand each person's specific needs. And each of our journeys is unique, as you know, and so a one-size-fits-all approach is not going to work. The second piece is to make your office hearing loss friendly. And I think sometimes hearing care professionals forget that we're here because we cannot hear well. So please set up the office so that we can feel respected and be able to participate. Third is to embrace creativity. So this is really, don't get trapped just in a hearing aid only approach. There are lots of other technologies that can be very, very helpful for people. Fourth is to think beyond the technology, and devices are obviously a critical part of helping people with hearing loss. But as Gail Hannon and I write about in our book that Sharon was talking about, there's so many other things, softer side type of things, behavioral change, attitude change, and we'll talk about those later. And then fifth is to support the hearing loss community. So there's a lot of advocacy that still needs to be done in order to make things more hearing loss friendly out in the world. And all of you as experts can really contribute a lot to that effort. So in the discussion, I'm going to cover each one of these in more detail with, with the pitfalls, some case studies to show the pitfalls, but I don't want everyone to feel sad walking out of here. I have a very good story, a good example to end with, so it'll be positive again. Okay, so let's move on to the first one, partnering with your patient. Okay, in the first case study, it was John's second trip to see an audiologist, and his hearing problems had gotten worse, and he knew he probably needed hearing aids, but he definitely did not want them. But he knew it was time. So he didn't know a lot about the types of hearing aids that there were. He didn't know about communication best practices. He didn't really know anything. He expected his audiologist to ask him lots and lots of questions. But the conversation really centered around, what type of device did he want? What did his budget seem like? What did he want the device to look like? And so he walked in scared and impressionable and really looking for answers. And he didn't really get a lot of that, but he did get a hearing aid. So he felt like it was more a successful visit maybe for the practitioner and less so for him. So what is missing in that scenario? Partnering with the patient, obviously. Okay, so the next slide is why should you partner with your patient? And I hope that this is a little bit obvious, right? Each person's journey is unique. They each have specific needs. Some people maybe are working. They need technologies that are going to help them in a work setting. Others maybe work on their own, but it's really just out at restaurants or socializing. So taking the time to understand what it is that they need, and combining that with all the technologies and information you do in terms of the audiogram, speech and noise tests, is really going to get them to the best solution. Okay, so how do you do this? Next slide, please. The first thing is to ask for their input. So I think to prepare for the appointment, you give them some homework. Ask them to think through the situations where they're having the most trouble hearing. Where are things going well? And write down as many details as possible, because then you can incorporate that into your recommendations. Second is to listen to their priorities. So it's really having that attitude that an audiogram is not everything. It's definitely something, and it's an important something, but it's how do you apply that to each person's personal situation. The third is to build the treatment plan together. And I think this is something just in human nature, right? That if someone's involved in the creation of a plan, they're much more eager to carry it out and to believe in it and to continue to do it. So involving them will help with that. And then setting realistic expectations. So work is definitely going to be required by you all, but it's also going to be required by the person with hearing loss. And I think sometimes we don't know that, we forget that. We think it's going to be just like glasses, you put the hearing aids on and poof, you're done. And it's definitely not that type of experience. Next is to empathize with their journey. I can't emphasize how much respect and compassion can go a long way in terms of creating that partnership and really building that trust so that we're more willing to take in the ideas and implement them. And then also to involve the family. The family is really your patient's most important support network. And so including them in that is going to be very helpful. Sometimes family thinks that, maybe the person's just not trying hard enough to hear, or they need to, turn their hearing aids up a little bit. And I think sometimes hearing from the professional how real the situation is, looking at that audiogram and seeing some of the issues can really put that type of attitude out of the family's mind. And that goes a long way in terms of developing that support that people need. And plus you'll learn a lot from the family, right, about where these people struggling, or maybe they don't even know what they're missing, right? That's a lot of the issue with hearing loss is sometimes we don't even know what it is that we're missing. So they can be helpful in that way also. All right, so the next way is to make your office hearing loss friendly. And another case study example. So Jill's tinnitus was flaring up, and she wanted to go to a doctor's office to get some more information. So she arrived and she went up to the receptionist, and the receptionist is sort of mumbling and typing into the computer. So she didn't know, is she supposed to have a seat, fill out forms, what exactly is she supposed to be doing? And she was very disappointed and surprised because this was a doctor's office for people with hearing loss. And the same thing happened on the way out the door. And she just felt completely disrespected and never went back to that hearing care professional again. And so what is missing from this piece is a hearing loss friendly office and experience. So next slide is, why should you do that? And I think this aspect is often overlooked by hearing care professionals, but it's really the first thing that your clients are going to notice, right? Is the office, is it easy to hear in the office? Is it hard to hear in the office? Are the lights up? Is the noise down? If there's a TV, is it captioned? All of these things are going to make people feel more welcome and feel like they're at the right place. And they're small steps to take, but I think they're overlooked. So how can you do this? So the next slide. And the first is really, it starts with making the appointment. So it's very challenging for people to hear on the phone when they have hearing loss. So make sure that your receptionist speaks slowly, clearly, and even better, maybe let appointments be done by email. When you call to sort of confirm the appointment, send an email or text. That is much easier. The next thing is to keep your office quiet and well lit. We all know how to set something up to make it conducive to good hearing. So make sure that that's the case in your office to the extent that you can. And I'd encourage you to share relevant literature in your waiting area. So there are brochures, maybe for a local Hearing Loss Association of America group or Hearing Life magazine. When we go in there and we see stories and information that's available, it helps us feel less alone in our struggles. And that's a huge part of being welcoming. And then use hearing loss friendly procedures. So I know when I go to the doctor, I'm always sitting there on high alert because a lot of times I'll miss my name if they're going to call it. So that shouldn't be the case of the audiologist or the hearing care professional, right? So maybe let them know when you're checking in, okay, we're going to send you a text, or maybe we're going to just come tap you on the shoulder. And that way they can sit there and relax and not be on high alert as they're waiting to go into the office. Small things. Also, I think it's important to supply a written summary of the visit. So a lot of people with hearing loss are embarrassed to say they didn't understand, or they didn't follow the information, or they didn't get all of that. So if you can supply it in writing, that takes away that issue. It also makes it easier for them to share it with their friends and family. And if they have any questions, they can refer back to it later on as well. And then the last thing for that is to make checking out at the desk stress-free, right? So maybe you have a hearing loop there or some kind of PSAP that makes it easier for them to hear and interact with the receptionist. Or, and if there's any financial information, obviously put that in writing as well. Okay, so moving on to the third one is embrace creativity. So our case study here is about Pedro, and he loves his hearing aids. He wears them all the time now, but he doesn't have them fulfill all his needs in all situations. And a lot of times if he's out at a restaurant or if he's going to the movies or the theater or some other place, he wishes that he has other solutions. And when he asks his hearing care professional about that, sometimes they suggest another program on the hearing aid or maybe a different volume control. But there are other things as well. And most of the innovations he uses, like speech-to-text apps or other things like that, he learned more from other people with hearing loss rather than his hearing care professional. So what's missing here is creativity. And why is this important? We go on to the next slide. And I think here it's almost like you have to do it at this point, right? Technology is changing so fast and people are aware of these changes. And so if you're not going to keep up, you're going to be left behind. And I think COVID-19 really did a good example of showing why creativity is such an important aspect. So with the masks, you know, we were struggling so much to hear, right? Because we lost the lip reading cues. And a lot of creative hearing care professionals and hearing aid companies created new programs, mask wearing programs, right? To boost up those high pitches so that are blocked by the masks. And so that's the perfect example of how creativity can really help enhance somebody's life. So I encourage that, you know, in every situation. So what can you do? Next slide. The first is I encourage you to spend a day in your patient's shoes. And maybe you do this in your training, I'm not sure. And, you know, so wear earplugs for the day. Now, it's not going to be the same thing, right? Because it doesn't mimic the distortion. But use them on your commute. Wear them at a family dinner. Wear them out to lunch with a colleague. See what it's like. See the frustration, see where you struggle, and that I think will give you a much better sense of things that you could suggest that might help them in their daily life. I'd encourage you to try the devices yourself as well, and not just for an hour or two. You know, wear the hearing aids. Obviously, they have to be programmed at safe levels. How do your ears feel at the end of the day? You know, what situations may there be feedback? What situations were more or less challenging? I think you learn a lot from that experience. Also embracing assisted listening technologies. And this you could do, you know, in conjunction with sort of these hearing aid wearing adventures. Go to the movies maybe, take out a caption reader, see how easy it is to manipulate. How does it help you to enjoy the movie or not enjoy the movie? Try out a hearing loop at a theater locally. All of these things, the more that you can experience life in their shoes, the more you can be creative in terms of creating solutions. Obviously being willing to teach, and that's something that's hard for people, right? That's not necessarily why people would go get into the profession, or, you know, maybe they like the technology side of it, or the analytical side of it, but putting that knowledge out to the world is really what it's all about. And then unbundling fees, which I know is sort of a controversial thing. But I feel like if you're able to charge for your expertise and your time, it's much easier for us to understand the value of that, right? Rather than have it being sort of all bundled into the price of the device. And so perhaps there are other issues with that in terms of insurance coverage and things, obviously. But it's something to consider because I think it shows a creative way to communicate to your clients how all those other aspects are really what you're paying for in addition to the device. Okay, so think beyond the technology. So Paula knows that she sounds like a broken record to her family and her friends. You know, I need to sit in the corner, please face me. And these are all important things that she needs to communicate so that she can communicate well with her friends and family. And for years, she didn't really know a lot about these communication best practices. And while they seem obvious today, she wishes that she would have learned about some of these maybe at that first appointment and every appointment thereafter with her hearing care professional. And over time, she learned these, but again, this is, I think, a missed opportunity to think beyond the technology. And so why should you do this? The next slide. Many people from hearing loss are really starting from scratch, right? We don't know anybody else with hearing loss. I mean, I knew my father, but he wasn't going to talk to me about it. He wasn't going to share any of these tips and tricks with me. And this is really one of the main reasons that Gail and I wrote our book, Here and Beyond, because we developed all of this knowledge over our lifetime with our experiences and also the experiences of all the other people with hearing loss that we know through HLIA and different advocacy initiatives. And we wanted to put it all in one place. And so you all are really important in being able to fill in some of those gaps. And I would encourage you to take the opportunity to focus on that as well. So how can you do that? Next slide. Oh, there you go. So first is to share these communication best practices. And again, I think some of these things are obvious, right? Don't cover your mouth, face the person, get their attention first. But they're obvious, you know, when they're obvious. They're not obvious before they're not obvious. And so I would encourage you to talk to the people with hearing loss and their families about these simple ways to improve communication. And you can even include them, you know, maybe on the back of that written summary sheet that you hand out. It'll show how important they are, and it'll make them very easy to share with other people. The other thing is to teach your patients to be better listeners, right? So we're reliant a lot on other people to make changes to improve communication, but there are things that we can do as well. So for example, scheduling important appointments for the morning, where for many of us, we're a little bit fresher. We're not as exhausted. Maybe we hear a little bit better. Keeping up on the news so that when you hear names or places or things of that nature, it's easier to sort of process and find that name rather than something that's just sort of a random word that you have to fit into your brain. Also, it's important to talk to them about how to manage hearing loss exhaustion. So we talked about, you know, I often feel exhausted at the end of the day, right, from all that energy that I'm putting into hearing and understanding. And I didn't know that that was normal. So I think if someone had told me that, that would have just gone such a long way for me to not feel bad about that. I wouldn't feel like a failure. I would feel like this is a normal part of the experience. And guess what? These are some ways that you can handle it. Life-changing. Also is to promote self-advocacy skills. So we really need to learn how to ask for the assistance that we need. Hearing loss is not a passive sport, right? It's very active. So you can really empower people and encourage them to do that. Small things like just even going like this in a conversation lets that speaker know that maybe they need to raise their voice a little bit more. And you don't feel bad for doing that. You're not interrupting the whole flow of the conversation, asking for repeats and all of that. And then recommending peer support groups. I mean, I can't tell you how important it was in my life to meet other people with hearing loss, in addition to my father. It was the first time that I really felt like there was someone who understood what I was experiencing. And this is true for hearing loss, this is true for any life challenge, but really that peer support is overwhelming. I've learned so much from people like that, and you can introduce us to those groups, right? There are probably groups, there are plenty of them. I think there's a Morris County chapter of Hearing Loss Association of America. I'm sure there are many in New Jersey. And if there aren't one, you can consider starting one for your patients. You know, there's definitely an opportunity there as well. Okay, so we're now at the fifth one, support the community. And at the latest Walk for Hearing in New York City, where I live, there were many audiology groups that came out, and lots of student groups too that came out to support the walk. And we were very excited to see them there, very warmly welcomed. And they were really good fundraisers too. You guys are good at that, actually. And so their efforts were met with a lot of enthusiasm. And so it was a time where we could all be on the same team, right? Sometimes people with hearing loss feel like maybe we're not exactly on the same team as our hearing care professionals we want to be. Sometimes we feel like we're not. This was an instance where we were all in it together in a very visible way. So why should you do this? Next slide. There's a saying in disability advocacy, which is nothing about us without us. And I think that's hugely important. It basically means that there should be no product or procedure or anything that's developed that's going to impact the person with a disability without including their perspective. And so I know Google does that. I'm actually one of the trusted testers for some of their different products. And I think it's also a wonderful standard for the hearing care community as well. The more that you understand and interact with the people that you're trying to serve, the better off your product and your service is going to be. So how do you do this? You can meet with us outside of the clinic, obviously, and the easiest way to do that is to come to an HLAA meeting. Has anyone ever been to an HLAA meeting? Oh, guys, let's put that as a takeaway from the presentation. We would love to see you there. Truly, truly. You can volunteer to speak at one, or just go and listen to the speakers, listen to the questions, soak up the ambiance. You'll learn so much about what's important to your clients. And then join our community activities like the Walk for Hearing or things of that nature. You can also help advocate for communication access. So there's so much advocacy that still needs to be done, installing hearing loops, making sure there are open caption performances at theaters and in public spaces. And your voice as an expert really takes a lot of emphasis. I mean, it really can have a very big impact on a state leader or a legislature, someone in the legislature. So I encourage you to use that expertise for that. Also educating the medical community. I mean, I'm always surprised at how often doctors overlook hearing loss, or they don't know as much about it as they maybe should. So you can work with some of them to explain some of the comorbidities and trying to get them to refer people to you for additional testing. And then promoting hearing loss prevention. So you could work with local schools, go in and talk to elementary students. I did that in my son's class many, many years ago. It's actually a ton of fun because these kids are so interested in everything. I mean, show them a decibel reader and they go crazy. And they walk around and they really do understand that, you know, if you're further from the sound, oh, look at that. It doesn't hurt my ears. It's very simple things, but it's a very valuable way that you can give back and educate others about that. Now, I know there's only so many hours in a day, right? So you're not going to be able to do all these things that I've suggested. But maybe just pick one or two of these in terms of the advocacy initiatives that resonate with you and do your best to incorporate them. So let's talk a little bit about barriers. So that's the next slide. Because this all sounds great, right? Like, let's do it. Person-centered care sounds like what everyone wants to be doing. So I wonder if there are some barriers that you would be interested in sharing as a group at this time. If anybody has barriers, like why doesn't this happen? No? Okay. All right. So then I'll talk to you. Oh, okay.
Well, obviously, COVID is a barrier because you've got these glass things in front of your secretary. You've got masks on, which you've been through. Those are negative to visuals, you know, supportive communication. And if you get necessary, the distancing is stretched out even further with double the distance at the country. So yeah, those are things that we've been all through for a couple of years now. It seems like
Some of the practices I work in are still going on. Because they certainly require stuff. Because we have a sensitive population, so it's not very high seniors. So those are the ones I can think of where we're at. And I think there's a fatigue on all sides of this, paradigm of the caregivers should be served by privilege. And also the practitioners practice because they're highly effective. It's only the most directed, they're in the mass, I don't believe it well. And it goes on, very, in two practices. They're just retired. And that's the part of the issue. Although hearing care, it's gotta be there for hearing care, I have to do one. And it's just that there's no voice, it's just a hard time. So, and I think how do you break it down, you gotta be positive, you gotta be very positive, to talk to patients, encourage them, realistic, and helping understand, yeah, it's a struggle, you gotta understand, this is what they do for the kid, you want them to.
Family members, a huge family. Sometimes you end up talking about the patient, not to the patient. Sometimes the family member, we all tend to be somewhat self-centered, so the family member may be focusing on his or her issues, but not necessarily the person with the hearing loss. And therefore, the person with the hearing loss becomes invisible.
That's great.
I would say the big one is economic concerns, as far as everyone wants to do all these things. And like you said, it becomes how much time can you devote to these things compared to how much money you make. It's like when it comes down to it, we all need to make money, so there's a trade-off. Right? So some people do it better than others, but it's a big one.
Plus, I think economic on the patient end also is they want everything for nothing, and you have resources to be able to help them with, but they don't want to put the money into that too, in their economic situation too. And there are some definite avenues that help more, but they have their own, patients have their own limits of what they can do.
Right, so there are barriers on both sides, really.
Yeah. And just piggyback on what Dan said, I think with economics, we have time constraint issues. So we want to be this way, and maybe we can be this way with our first patient, and then we have business, criteria that we have to deal with, scheduling limitations, meetings and seminars, and things like that just really bind our time, and as Chip said, it's exhausting. And, it really, it makes it a lot harder for us to just be, centered on the patient's needs. It's really a stretch.
Well, thank you for sharing all those. I mean, I hear all of that, and those are all excellent points. And they resonate, I think, with a lot of what I've heard in the past. So if you go to the next slide, I can show you some of the common ones that I hear. It really resonates with a lot of what you all were saying. Not enough time, right? In the appointment itself, even. And some suggestions for that would maybe be doing some of that homework ahead of time, letting the patient be more prepared to come in, having thought through some of the situations that they really want to focus on, and maybe explaining to them, this is the layout of the appointment. This is how much time we have. We're going to spend this much time doing this and this much time doing this. And perhaps that helps them understand a little bit more that their input is important and this is where they have that opportunity to give it. But it's definitely an issue. Also, not having the necessary counseling skills. And I don't think anyone mentioned that one necessarily. But I think that's a big deal. Counseling is hard, right? And sometimes that needs to be a bigger piece, I think, of the curriculum that you all are going through and training on that, because counseling isn't something that's for everyone or comes naturally to everyone. Also, emotional discussions sometimes make people feel uncomfortable, right? I mean, people are probably not happy in your office a lot of the time, especially the first time that they're there. And so I think I'll just encourage you that just because your patients are emotional, it doesn't mean that you have to be emotional. And that really, they're not expecting necessarily that you're gonna have the perfect thing to say. It's just listening and sort of having that empathy and that compassion. And that can really go a long way, just a little bit of kindness. And then selling hearing aids is my livelihood, right? We talked about that one, and that's definitely challenging, right? It's like, how do you make sure that you're getting paid for your time and able to contribute? And I go back to the unbundling, but you know, that's hard, right? Because there's this legacy of putting everything into the hearing aid. So people don't want to necessarily pay for a lot of these free services because we've been trained that they are free services, and they're not free. They're actually the real crux of what's happening there. So we all need to sort of change our mindset there. And then some people think my patients have done fine without it. I don't think there's anyone in this room that thinks that, but sometimes I do hear that as well. And I would encourage people, if they think that, you know, maybe do a survey, maybe see if it's really true, or try it and see if their patients actually do better with person-centered care. Okay, so what the next slide is, what is the client role in all of this, right? Because you guys are not miracle workers, maybe a little bit, but we need to contribute as well. So what do we need to do? We need to share our hearing loss story and our struggles. It's not the time to play Mr. Tough Guy. You know, maybe people come in and say, I'm not really having any issues. We need to be open and we need to be vulnerable. And we may need your help to get there. So ask us the questions that can really draw us out. We need to be responsible for coming armed with facts, right? Back to that homework again. The more specific details that we can give you about this situation went well, this situation didn't well. I tried this program, I tried that. Write it down so that we can give you the information. Also leaving anger at home, and that's tough, right? Because hearing loss is frustrating. But if we come in angry and blaming others for the issue, we can really miss an opportunity to find a creative solution. So if we're angry, you know, acknowledge us. I see you're angry. I understand it's very, very frustrating. But let's try and focus on some creative solutions and see if there's a way to sort of divert the conversation. We also need to respect your expertise, and I think most people with hearing loss do, but it's important that it's a mutual respect, clearly. And then we can teach what we know. Like I'm finding apps all the time, like different speech-to-text apps, the new iOS and Apple has captions built right in. FaceTime now has captions built right in. I don't know if you guys know about this, but your patients probably do. And so if we tell you about them, then you can pass them on to the next people. And then staying in touch, right? I mean, hearing aids are not like glasses. It's not like you walk out the door and you don't have to maintain them. They need to be cleaned, they need to be serviced, your hearing needs to be checked, so we need to take that into consideration as well. And like I said, we may need your help in sort of reminding us and educating us about our responsibilities. So change is hard, and so I don't want this to be a discouraging discussion. You know, I know that I sort of put a lot of things out there. It can be very overwhelming, and that is not my intention. My intention is to sort of inspire you to take little bits of this and incorporate it the best that you can. It doesn't have to be overnight. It can be gradual. And so I wanted to end with a positive story for this part of the presentation, because I promised that I would. So this is a story about my current audiologist. So I wear lyric hearing aids, which I don't know if you're familiar with. They're sort of extended wear, deep in the ear. And I really like them. They're not perfect solutions, but they work well for me. I can hear my kids at night. I can do all my sweaty hot yoga, and I can wear my hearing aids. But a couple months ago, they were shorting out quite a bit. They were just, I don't know, it was like liquid. They would just die. And so I knew I needed to talk to my audiologist about it. Went in and he explained to me that I guess this is a common issue, that you would get liquid in your ear or fluid in your ear. I've been wearing hearing aids for 20 plus years. It's a new thing for me. But I was educated, and it was, you know, annoying because I had to deal with this, but he explained it to me. And I was also planning on going on a trip. And so I was worried, what if this happened when I was on vacation with my family? So we talked through the issues, he educated me, we came up with solutions of how I could handle this on my own when I was away. And he gave me some extra lyric hearing aids to take with me so that I could take them out, put them in. And it was just a tremendous experience. I felt heard, I learned something, we were a true partnership, and my problems were solved. And I left that feeling like this is somebody that I can trust with my care. And I wish every appointment was like that. So that's it for this part of it. I want to thank you for your participation and your attention, and this is all of my details, how to get in touch with me. I don't know if you have any specific questions about this, if you want to take a break before the next one, or just go right into it. It's up to you. Any questions about any of the person-centered care stuff? Yeah.
I have one question. What do you think of as a hearing impaired individual implementing some of the self-help programs for retraining therapies for speech and noise? There's some programs that are out there that if you cost something to the patient or on our end to be able to provide, and would you, how many would you, or do you within the hearing impaired people you talk with will use this and benefit by it?
That's a great question. So the question is where there are sort of these oral rehab programs that cost money both for the practitioner and the patient. You know, do people want them? Who's going to use those? I think they're terrific. Now, again, it's getting people to see the value in them. So maybe there's a way of doing a trial so that people can see that they're getting benefit from it before they're laying out a lot of money. You know, for better or for worse, a lot of people with hearing loss are on a fixed budget, right? And so there is definitely those economic issues. But that's really what it's all about. I mean, it's not the hearing aid itself. That's a critical piece, but it's not enough to get you where you need to be. And so if there are training programs, I think the world of them. And, you know, HLAA, other organizations that represent people with hearing loss are very much behind these types of trainings. Okay. Well, we can go on to the next part of the presentation. We're gonna get another slide deck up and going. Now this one has a bunch of videos in it. I don't know how effective that was. So you guys tell me if you want to watch videos that don't have sound or if we want to skip it. How about we watch them? Let's see. Yes. And how about we skip it? We'll see how it goes. If it gets like, this is stupid, just tell me.
Are they closed captioned?
They are. They're all, of course, all my videos are closed captioned. They all come from the documentary We Hear You, which is closed captioned. Okay, so the first part of the talk was all about sort of person-centered care and more about the things that we would all love to see from our hearing care professionals. And this part of the presentation is about sort of the other side of that, the person with hearing loss, right? So the person that's sitting across the table from you. And hearing loss doesn't really come with a how-to guide, right? So you have hearing loss and you don't necessarily know what to do about it. So this session is sort of that roadmap for your patient. So hopefully my goal in talking to you about this is that you sort of can incorporate some of this information into what you're talking about with your clients, and then also refer them to things like this book or like this documentary or like blogs or Facebook groups or whatever that's out there in terms of that peer support so that they can learn some of this information on their own as well. So what I'm going to do is I'm going to talk about the stages of the hearing loss journey, and then talk about how you live skillfully with hearing loss. And so there's a formula that we go through. in our book, and so we'll be talking about that. And I don't use the word skillfully lightly, right? When we really started, Gail and I started working on the book, we're thinking, okay, do you want to live well with hearing loss? Do you want to live successfully with hearing loss? We said we want to live skillfully with hearing loss, because that means it's something you can learn. There are skills that you can apply, that you can learn, that will help you live better. So that's just an important piece of it. That's a very skill based approach. And we've based this approach not just on our own personal experiences, but the experiences of many, many other people with hearing loss as well. And I believe that they're corroborated by science, by research, by tremendous advances in technology, and also by person-centered care. So I'm excited to share some of this philosophy with you. Okay, so the next slide, and as we talked about earlier, each hearing loss journey is sort of unique, and I shared mine with you. There's definitely similarities and differences, but when Gail and I got together and we started talking about it, the thing that we realized is that when everything changed is when we shifted the goal, right? It wasn't about hearing better, it was about communicating better. And it's a very subtle shift, but it's a shift in something that we can be successful in. We are not going to hear better. We'll hear better, but we're not going to hear well, right? Even with our devices, we're going to fail, but we can communicate better, right? And that's what it's really all about, is that connection with people. So if you can shift that mindset in terms of what the goal is, I think your patients will be much more successful. Okay, so let's go to the next slide. And let's talk about, why are some people more successful with their hearing loss than others, right? Because it really does vary. To some extent, we all share the same challenges, right? But some people adapt to those challenges better. First is really how well a person thrives is sort of their life experiences, right? So what's the degree of their hearing loss? What type of, audiogram do they have? I have a little bit more of a cookie bite, which makes it hard to fit me. So it's always sort of a challenge there. The personalities, how do they do in challenging situations? How do they adapt to change? How comfortable are they disclosing and asking people for help? These are all important aspects. How well do they understand hearing loss? So it's a whole education process, right? You guys know a lot about it because you studied it. When you don't sign up to study hearing loss when you have it, you sort of have to take the extra credit class. And then the family attitudes are also an important piece of it. I really struggled a lot with stigma because I learned it from my family, and other families are sometimes not as supportive as I'm lucky to have my immediate family right now. And again, turn up your hearing aids, pay more attention. So the way that your family is approaching it can have a big impact as well. And then, of course, access to hearing healthcare is something that's not available for all people. A second big influence is all of you, right? The service that you provide. So imagine having a qualified hearing care professional who cares about your needs, who teaches you communication strategies, who makes you feel empowered. This is a huge positive impact on a person and their journey. And then on the other side, there's sometimes you go in and maybe you don't feel as heard or as understood or as respected. And that can have a negative impact in terms of the beginning of that journey. And then the third influence is peer resources. And I'm a little bit of a broken record on that, so I'm going to be talking about that quite a bit. And it was a life-changing experience for me. It took me from being isolated and ashamed and frustrated and sad to being part of a larger community of people that I was inspired by and who I could learn from. And now it's such a huge positive part of my life, so it's sort of a silver lining of hearing loss. Okay, so the next slide, please. And this is, what does it mean to live more skillfully with hearing loss, right? So we have a little bit of a formula here. And the first step is understanding what to expect, right? The big picture is what we call it. And because if you don't know where you're going in terms of your hearing loss journey, it's pretty hard to get there. And so this allows you to see, if you can understand sort of this big picture, it lets you see that ups and downs are part of the process, right? Hearing loss is not something where you check a box and you solve it. It's not a problem. It's a journey where there's going to be ups and downs. And so if you understand that, when you put the hearing aids on and they don't immediately work, you don't feel that you failed. You say, okay, well, that was supposed to happen. And then now I'm going to do step 2. So it's laying out sort of that path. The second step to living skillfully is embracing what we call a 3-legged stool of skills to improve communication. And this includes changing your attitudes about hearing loss, something that we call mind shifts, which we talk about, embracing a broad array of technology, so hearing aids, but other assistive listening devices as well. And then non-technical communication, game changers, things like behavioral change, communication best practices, things like that. And then the third step is putting it all together, which is easier said than done, right? So it's taking what you know about the journey, the 3-legged stool of skills, and then applying them in your life in different situations, in your family, your friends, your work, all different types of environment. So let's take a look at the hearing loss journey itself. So next slide, please. Okay, so most of us don't start off with a good view of the big picture, right? So this is something you can help us with too, in terms of setting the stage at the beginning, explaining that it's not like, we're not going to give you the key to the castle, but it's going to be sort of this thing that, that we're going to work on together. And the big picture shows you that there's support available, but it also shows you that it's okay to ask for help. So let's look at the next slide, which is the 5 stages of the journey. And so again, every journey is different, but most of them, can you do the next slide for me? Most of them show 5 distinct pieces. And so the first one is really debating with yourself. And this is if you wonder if you're having trouble hearing, or is everyone else mumbling? Maybe you're just having these subconscious suspicions. Maybe you're just in denial. A lot of times this stage can last 7 to 10 years for people. It lasted a long time for me, with help from my first hearing care professional who told me, well, there's not much we can do for you. But this is definitely a stage of the journey for sure. The second stage is validating, and that's when we finally, get smart and come to you all and get the hearing test. And it might not be what we wanted, but at least now we know that there's something we need to deal with. The third step is taking charge. And I think this is the most exciting part, because it's when you finally acknowledge it and you decide that there's something that you can do about it. And this first step's often getting hearing aids, but again, there's a lot more to do than just that. And then stage 4 is living skillfully. And that's really the goal, right? That is the ultimate goal and phase of living well with hearing loss. And here you're open-minded about trying new solutions. It doesn't mean that every day is going to be perfect, right, when you're in the living skillfully phase, but you know that that's going to happen. You're okay to and open to adapting, trying something new, and that's just part of the process. And then there's stage 5, which is refreshing and restarting. And this is kind of what makes the hearing loss journey a little bit more of a journey rather than sort of that thing that you can solve, because it's always changing, right? Maybe you finally think you figured it out, but your hearing loss gets worse. Or a pandemic comes along and it changes all the rules and you need to learn how to adapt all over again. And so this might take you back to a different part of the journey, a different phase of the journey, but it's just, you have to look at it as an opportunity to just learn more skills and continue to move forward. Now, in reality, some people are never gonna get out of stage 1, right? And some people might be so shocked by the diagnosis in stage 2 that they sort of run for the hills. And parts of 3 and 4, you know, can happen at the same time. But I think with support and understanding, everyone with hearing loss can have improvements and live more skillfully. And so that's really, you know, our goal with the book, and I know your goal in terms of helping your clients. Okay, so let's go to the next part of skillful living, and that is the 3-legged stool. And so the thing about a 3-legged stool is that it never wobbles, you know, even when the ground is bumpy. If someone can explain to me why that is, I would love to know, but it's true. And so that's why we kind of talk about it this way. And the legs are mind shifts, technology, and communication game changers. And each of them is important in and of itself, but when they work together, it's really when the magic happens. So the next slide, please, is a quote. "I have the potential to change my journey. The person with the most power in my hearing loss success is me." And this is really a moving statement, and it's a life-changing one because it's the moment that you discover that you are in charge of your hearing loss and your journey, and that a lot of that comes down to attitude. So the next slide, please, is going to show you some common attitudes that people feel about their hearing loss. And you may be familiar with some of these. But, you know, people ask themselves, why me? They say, nobody understands what I'm going through. I want to hear better the way that I used to. I don't like to advertise my hearing loss. People will think I'm old or slow. My family and friends always forget about my hearing loss. Hearing aids are ugly, they're expensive, and they don't always work. I don't want to bother anybody with my hearing loss needs. And who would want to hire me or love me or be my friend? I get angry at myself and others when we make communication mistakes. And everywhere I go, there's no access for people with hearing loss. So these negative attitudes feed into that stigma, right, that can prevent us from asking for the help that we need. And so stigma is such an important piece of hearing loss that I wanted to show this clip that I'm hoping is going to work, but talks a little bit about stigma. so I hope that was okay. I always love that story about how she literally let someone throw her hearing aid in the garbage rather than acknowledge that she had hearing loss. And I mean, it's like we can laugh at it, but it's just, it's so indicative, right, of the way that we put that onto ourselves, and it's just such a shameful thing. And it can't be. So let's go to the next slide. And I think that the clip really shows you that the attitudes that we have towards our hearing loss affect our emotions, and they also affect our behaviors. And this is very, very powerful because it means that life with hearing loss can be different. It can be better if we change our attitudes about it. And so these better attitudes help us create better communication and better conversations because we're more willing to ask for the help that we need. And they might make our technology work better too, right? Because we're more willing to experiment. It just gives us a little bit more freeness of feeling. And so when we can reframe our unproductive, destructive thoughts about hearing loss and turn them into constructive, actionable statements, we'll have a healthier approach. Now, I'm not trying to be overly simplistic, right? A mind shift is not going to cure hearing loss, but when we actively support our technologies with other skills, including a better attitude, we will do better. We will live more skillfully. So let's look at a couple examples. Next page up. So the first, the attitude is nobody understands what I'm going through. And the mind shift is that many people experience the same challenges as I do. I can learn from them. I'm not alone. And this is when, the power of that peer support, right? So when I first realized that I was losing my hearing, I didn't know anyone except for my father. And he wasn't going to discuss it with me. And I didn't know anyone to commiserate with. And I got my first hearing aid was in 1995. But I didn't meet anyone else with hearing loss until 2010. That is 15 years that I know of. I may have, but we didn't tell each other, right, that we had hearing loss. And that's 15 years of wasted time. And it took me another 5 years to discover Hearing Loss Association of America. And that was life-changing, as I mentioned, because I didn't feel alone in those struggles. I felt supported. I understood that there were others like me. I didn't feel like an outcast. And I learned so much from people. And I was inspired by watching all these people with hearing loss out there doing great things. They were teachers, they were entrepreneurs, they were musicians, they won Grammys. I could do it too. It gave me confidence that I could do it too. So let's see. So I think there is another clip for the peer support. Do we want to watch that? No, okay, so let's click. All right, so let's go on to the second example on the next slide, second example of a mind shift. And here the attitude is, I want to hear better the way I used to. And the mind shift is, I want to communicate better. And it takes more than hearing aids to do this. I must use other skills and additional technology. And this is really what we talked about at the beginning, right? It's sort of shifting that focus from the hearing to the communicating. All right, so let's go to the next slide. So say your client's like, okay, I'm all in for this mind shifts. How do I do this, right? This is not an easy process. So there are a couple of strategies to do that. And the first is really to talk about optimizing rather than perfecting, right? So sometimes perfect is the enemy of the good, right? And so we need to shift our goal to making it better, not necessarily to making it perfect, because communication situations are going to be challenging, period, end of sentence. But we can make them less challenging, we can make them better. So trying to have that sort of a goal in mind is helpful. The second is practicing to build confidence. So, how do you identify yourself as someone with hearing loss? I would always tell strangers first. Like when I was first starting out, someone next to me on the bus or on the airplane, I have hearing loss, so I might not hear the announcement. If there's something important, can you let me know? And then each time you do it, it becomes easier and it's just lower risk. Who cares? You're never going to see that person again. Practice, practice, practice. And then reinforcing the new attitudes. Things like a mantra. It sounds silly, but what you tell yourself is what you start to believe. Talk about how I can do this. Look at yourself in the mirror. I am going to focus on communicating better. And if you say that to yourself every day, eventually that's going to sink in. And then prioritizing self-care. This is an important thing for everyone, but one of the major realizations that Gail and I had about how we do well with our hearing loss is we take care of ourselves. We need to have energy. We need to have mental stamina. We need to have ways to deal with our frustration. So meditation, yoga, exercise, whatever your thing is, take care of yourself. Even if it's just sitting in silence for 5 minutes a day, with listening